morning, everybody. Bonjour à toutes et tous. We will get started. So it's a great pleasure and honor to introduce our esteemed visiting professor from Seoul National University, Professor Hee-Joon BAE, who's staying with us for 3 months, actually, here until the end of November. Before I forget, please, if you're interested in discussing things with Professor BAE, as he will be here for a few additional weeks, please don't hesitate to reach out, and we are very privileged to have Professor BAE stay with us. Professor BAE is a professor of neurology, who is also the current chair of the National Stroke Society in Korea. Extremely well connected in the stroke field, not only in Korea, but worldwide. I had the great privilege of meeting Professor BAE, I forget how many years ago, I think through an invited editorial that we were asked to write together for a journal, and this developed into wonderful collaboration over the years, and through, in particular, but not only genetic studies. And so Professor BAE has a huge dedication to research on stroke. So his research is on the epidemiology of stroke, but also stroke care, stroke pathways, patient pathways, pathways of patients with stroke. And he has also a great interest in vascular cognitive impairment, and has produced a huge amount of high-level research in this field. He has received numerous awards, amongst which very prestigious award, the David Sherman Award of the American Heart Association, also a national award for his achievements in medical research that was handed over by the Prime Minister of Korea. And so we are very lucky to have Professor BAE stay with us. He already had the opportunity to meet several of you, and we have numerous additional collaborations that are being established through this visiting professorship, and he will share today his experience, vast experience on stroke registries in Korea. And he has been and is the PI of numerous studies that have collected clinical but also biological and imaging information on patients with strokes throughout Korea. Very prominent studies that we are privileged to collaborate with. So, Professor BAE, June, please. Thank you.
Thank you for your kind introduction. Bonjour à tous. Je m'appelle Hee-Joon BAE. Je viens de Corée. Merci. It's very hard to pronounce French for me. Today, I'll talk about the registry, the past, present, future of a stroke registry, and based on my experience, almost more than 15 years in Korea. First of all, I had to mention that I'm just a representative of all the researchers devoted in this registry, and as well as the patients who gave their data to improve stroke care in Korea and outcomes. Stroke is a second leading cause of death in Korea. In 2004, its mortality is 2 times as high as other countries. The aging of our society may be the fastest in human history. The proportion of senior citizens aged 65 or older was 7% in 2000 and was expected to double in 2015. Furthermore, you can see in this the red line, total fertility rate is more than 6 in 1950s, but it dropped less than 1. Nowadays, in 2023, total fertility rate is 0.7 is quite low. Due to this rapid aging, stroke was expected to become an enormous burden on our society. According to the national claims data, the number of stroke cases increased by 60% from 2005 to 2012. Furthermore, at that time, primary and second prevention is inadequate, acute stroke care was insufficient, public awareness of stroke was low. To begin with, we had no national stroke guidelines. Our government decided to fund stroke research to address this crisis. Thanks to this support, the Clinical Research Center for Stroke, led by mentor Professor Byung-Yoon, was established in 2006. Our primary objective was to develop national stroke guideline and ensure their implementations. To achieve this, we focused on building stroke research networks and doing clinical trials, as well as the epidemiology and quality of care research. We aimed to improve the quality of stroke care and reduce stroke, improve the stroke outcomes in Korea. The CRCSK was organized into 6 sections. The first section focused on the development and implementation of stroke guidelines, while the 6th section was responsible for the establishing multi-center network. I'm in charge of 5th section, which is responsible for the epidemiology and quality of care research. We had a dream. It's World Cup 2002. The CRCS was a 9-year project. After its conclusion in 2015, the investigators from the CRCS-5 decided to continue our collaboration. Fortunately, we succeeded in securing financial support from Korean NIH in 2017. Our registry, now called as CRCSK NIH. For stroke epidemiology and quality of care research, we established a prospective multi-center stroke registry. As mentioned earlier, the project began in 2006 and case registration started in 2008. Basic database structure was developed over 5 years. Initially, the registry started by just collecting baseline characteristics. Later, it was expanded to include quality indicators, hyperacute treatment, and outcomes, and stroke subtypes. Currently, we are collecting about 500 variables for each case. In terms of participating hospitals, we just started with 9 centers. Nowadays, 20 hospitals across the whole country are participating in our registry. We have a web-based registration de-identification system. All the processes are conducted online. Data quality is our primary concern. All the data are downloaded and verified for accuracy on a monthly basis. Initially, number of query volume for months was more than 5,000, but it decreased less than 2,000 nowadays. We continuously strive to improve and maintain highest standard of data quality. Garbage in, garbage out. To date, we have collected more than 110,000 cases, 90% were ischemic stroke. During last 3 years, an average of 771 new cases are registered each month. Our patients come from across the whole country. The figure on your right side shows the distribution of home address of 40,000 cases registered recently. Our patient population is also representative of the overall stroke population in Korea. The demographics, stroke severity, and this disability at discharge are similar to our national audit data. Regarding the ischemic stroke subtype, large artery disease is most common, 35%, followed by the cardioembolism and small vessel occlusion and other determined etiology among the patients with determined etiology. Proportion of undetermined etiology is around 20%. It is relatively lower than compared to other registry. Since 2012, we have published the basic statistics of registered cases on annual basis. You can get the report on our website or request it directly from me. You can see my email is quite easy to remember. brain.snu.ac.kr. The detailed information about our registry was published in International Journal of Stroke in 2014 and Journal of Stroke in 2015. Have you been successful in improving stroke outcome? I would like to believe the answer is yes. So, we analyzed 10-year trends from 2000 to 2020, examining the 48,000 patients with acute ischemic stroke or TIA. TIA was about 9%. The mean age of patients has slightly increased for both men and women, 2.2 years and 2.4 years respectively, with a slightly increasing proportion of men. Despite of our slightly older demographics, the prevalence of major risk factors remained stable. Current smoking decreased a little by 2.6%, but newly diagnosed dyslipidemia fell by 29%. Stroke severity at present is also decreasing. The mean NIH stroke scale is 5.4 in the 2011 and 5.1 in 2020. The proportion of mild stroke increased and proportion of severe stroke decreased. Over the past 10 years, the implementation of advanced stroke treatment has improved significantly. Starting for the large artery disease of 82 to 95%, and the dual antiplatelet therapy for mild stroke or TIA was 64 to 40%. The anticoagulation for the atrial fibrillation is 33 to 67%, quite huge difference. Stroke outcomes also improved. Neurologic deterioration during hospitalization, length of hospital stay, 3 months and 1 year mortality improved significantly. Symptomatic hemorrhagic transformation after reconnaissance therapy remained stable at 3%. The cumulative incidence of recurrent stroke at 7 days, 1 month, 3 months, or 1 year also improved. Interestingly, this decline varied across the stroke subtype, with a notable reduction in large artery disease and cardioembolic stroke, but with no change in small vessel occlusion. We should do more for small vessel occlusion. According to the national death statistics in Korea, stroke mortality is decreasing in South Korea. It was 71 per 100,000 in 2004, but dropped to 43 in 2020. 40% reduction for 16 years. Do you think we have done well? However, functional outcomes, more specifically 3 months MRS, 0 to 1, 0 to 2, at 3 months, 1 year, did not improve. What more can you do to improve the functional outcome? This slide highlights the areas that can be improved. The rate of pre-stroke anticoagulation for AFib and median node arrival time, the proportion of receiving perfusion image within 24 hours, the patients treated by the endovascular treatment within 60 minutes from arrival, and IVT treatment and EVT treatment. CRSSK is a stroke research network. Our team consists of 110 researchers and research coordinators working across the 20 university hospitals or regional hospital centers, even in Jeju Island. Have you ever been here? It's a very beautiful island. You should go there. We have actively cultivated researchers. Over the past 15 years, we have conducted numerous workshops and symposiums to train them. As a result of all of this effort, we have been able to publish over 200 papers based on our registry. This slide outlines the development process of our stroke guidelines by the CRCS project. We begin by collecting and analyzing stroke guidelines from other countries. After reviewing them, we decide to adapt them as a primary approach. After a 3-year report, we successfully developed our guideline and began to distribute our guideline in 2009 to the members of our Korean Stroke Society. This guideline was endorsed by the most of other academic society involved in stroke care in Korea. We provide education for our guideline through the education course, Neurology residents at Academic Conference of Related Society. We distributed more than 2,000 copies of the Korean edition and 1,000 copies of English version between 2009 and 2010. Both versions were open to the public in our project website. In 2015, we evaluate the impact of guideline publication on clinical practice using data collected from our CRSSK database. As you know, evidence did not support the use of heparin for acute ischemic stroke. However, prior to the guideline publication, the heparin is used quite open in Korea. A total of 23,000 cases with acute ischemic stroke registered in CRSSK between 2008 to 2013 were analyzed, and in the on the figure, you can see the heparin use is quite open. The determined etiology, undetermined or cardioembolic stroke between 2008 2017. However, the heparin use is steadily decreased throughout the study period. When the date of admission was dichotomized into pre and post guideline release, it was associated with reduction of heparin use. The odds ratio was 0.74 independent of the year of admission year. Most of early studies focused on the prognostic and stroke risk factors. We examined the effect of asymptomatic hemorrhagic transformation or blood pressure of our presentation on stroke outcome. We also analyzed the moderate alcohol drinking and aortic arch disease as a stroke risk factors. We validated I-score. We estimate population attributable risk of the traditional risk factors in Koreans. We explore the gender difference and the vascular event rate after stroke. But our research effort after the establishment of stroke registry have focused on 5 key areas. First area is comparative effectiveness research, CER. You know well the comparative effectiveness research. After the US government announcement of 2009, there was a huge investment in this area. I believe CER is an excellent option for stroke research. Due to the heterogeneity of stroke, we cannot get all the answers through the randomized clinical trial. But in such cases, CER could provide a valuable insight. Many of our recent publications have utilized CER research methodology. This slide provides an example. When we examined the proportion of low-dose TPA use among patients receiving IV thrombolysis, we found wide variations, ranging from 0% to 97%. This disparity indicates clinical efforts, at least in Korea, offering an opportunity for CER. So we conducted a study. Comparison between low dose and standard dose TPA revealed that there is no difference in 3-month functional outcome. However, there is a reduction in 3-month mortality in low dose group. This study, published in Annals of Neurology, is a representative example of CER based on our registry. We compared the stroke registry between patients who were taking aspirin before the index stroke and those who were not. Initial NIH stroke scale were lower in pre-aspirin users compared to the non-users, with the most notable reduction in patients in large artery disease. As expected, the pre-aspirin use increased the risk of hemorrhagic transformation, but reduced the disability at discharge. This effect of pre-aspirin use was confirmed in another study using cerebral impact volume as an outcome measure. This study is another strong example of CER based on registry. We investigate effect of statin in statin-naive patients with a pre-stroke LDL cholesterol level below the recommended target, less than 7 milligram per deciliter for large artery disease, less than 100 milligram per deciliter for non-atherosclerotic stroke. Among the 1,900 patients, 13% had atherosclerotic stroke. Overall, pre-stroke statin therapy was associated with lower risk of major vascular events, including stroke, MI, deaths during 1-year follow-up. weighted HR is on the 0.55. These figures shown here suggest this effect differ by ischemic stroke subtype. The statin effect is significant in all stroke, particularly in large artery disease. However, it is not significant cardioembolic stroke and small vessel occlusion. Dual antiplatelet therapy is another focus in our CER. First, we examine whether the result of chance and point trials could reproduce, and the answer was yes. Adjust HR is 0.76. However, the superiority of dual antiplatelet over the monotherapy is seen within 1 month. In Asia, our major concern is intracranial artery stenosis. A sub-study of chance showed that significant but small difference in patients with ACAS. Again, CR-based our registry indicated the benefit of DAPT might be extended 1 year, 1 month up to 1 year in patients with large artery disease. Current guideline only support of use of DAPT for up to 3 months in patients with severe intracranial stenosis. So we decided to conduct a registry-based randomized clinical trial to check whether we can use a DAPT over 3 months. It is quite common in Korea and other Asian countries. The duration trial is the first registry-based randomized clinical trial in Korea, comparing 3 months, DAPT for 3 months versus 12 months in patients with acute ischemic stroke due to the large artery disease. We plan to enroll 4,800 patients. The 42 patients have been enrolled. The protocol was published in 2023 in International Journal of Stroke. Stage 2 is another RRCT which began last year. 21% of target population have been enrolled. CER-based our registry published in Neurology in 2020 suggested statin may be effective in preventing major vascular event, especially all-cause of death, within 3 months in patients with acute cardioembolic stroke with no guidance-based indication for statin. Stage 2 aims to prove statin may be effective in cardioembolic stroke without indications. CHOICE is a third RRCT based on our registry. It just began. Our aim is to determine the effect of cilostazol, which is known to effective small vessel disease, compared to aspirin or clopidogrel monotherapy in preventing post-stroke cognitive decline in high-risk patients. We are working on connecting our registry database with other data sources. By collecting additional MRI data taken during the acute stage of stroke, we reported the vascular territories of supratentorial arteries maybe differs slightly from previous knowledge. This slide presents another example. We analyzed MRI data of about 4,400 patients with first ever ischemic stroke and atrial fibrillations. Cobalt brain infarction instantly found on the clinical routine MRI was detected in 42%. It's quite common. And it was associated with increased risk of recurrent ischemic stroke, but not all cause of death. The hazard ratio is the 2.91. We linked our registry data to national claims data and found that 5-year health cost after stroke varied significantly according to the multiple ranking scores. The average cost for patients with multiple ranking 0 to 1 around $55,000, while for MRS scores 4 to 5, the cost is more than $250,000 with a more than $200,000 difference over 5 years. It means we save just one person, save $200,000. That is our rationale to persuade our government. International collaboration is a crucial area. Our truth comes through collaborations. This slide presents a list of projects we are currently collaborating on. One of the key reasons why I'm here in Bordeaux today is explore further opportunities for collaborations. This study is a great example in the international collaboration, I think. This cohort study compared the acute ischemic stroke patients receiving intravenous thrombolysis based on the pre-stroke DOAC use and concluded that the pre-stroke DOAC use did not increase the risk of symptomatic hemorrhagic transformations. We are eager to collaborate to the improved stroke outcome. Please feel free, reach out to me, to us. Last keyword is genetics. GENIAS aimed to estimate the prevalence of and the characteristics of 15 monogenic disorders in large, unselected, young age stroke populations. 55 years old or younger, and to evaluate the relationship between these mutations and clinical and neuroimaging characteristics. Target gene sequencing for 15 monogenic stroke genes in 15 disorders were conducted. The coverage for target genes was quite high. The analysis result of the first 1,000 cases were recently published in Annals of Neurology. Among the final 4,112 cases, 15 to 6% has 63 clinically relevant genetic variants according to the ACMG classifications. The figure on your left shows that the proportion of CRGBs varies according to the ischemic stroke subtypes. The highest proportion is the determined etiology, followed by the large artery disease. Cardioembolism is maybe the lowest. The figure on your right shows the prevalence of CRGB according to the age group. The prevalence decreased with aging. The most common mutation was found in the RNF213 Moyaman disease, 6.6%, followed by ABCC6 genes in 2.9%, and NACH3 1.7%. We have no APP mutation. In summary, the prevalence of CRGB is in Mendelian stroke genes not rare in young Korean stroke patients. I don't know exact meaning of this clinical implication. We should do more. Furthermore, the analysis of first 1,000 patients showed that only a small portion of patients with the clinically relevant genetic mutations, 27 for the RF213 and NACH3, show typical clinical and neuroimaging characteristics of corresponding monogenic disorders, which means the more than half of patients have no features of corresponding disease. So we will need to monitor these patients to see how their condition evolves. We know well the success of Chance trial. The 60% of East Asians are carriers of CYP2C19 loss of function allele. The trial demonstrated that patients carrying this allele had better outcomes when treated by ticagrelor compared to clopidogrel. However, despite of this success, pharmacogenomics are not implemented in our clinical practice. We did not use the CYP2C19 did not check this mutation in our practice. Why did it happen? We thought, I think the most important reason is the lack of our own data. Looking at GWAS, the East Asians account for only 3%. Regarding the genome sequencing, Koreans represent just 1%. The need for data specific to the particular ethnic group is evident, as you can see on the right. The polygenic risk score developed by Europeans did not work well in East Asian and Africans. Genesis K is a nationwide multi-center pharmacogenomic cohort study of acute stroke patients. This study involves registering patients admitted for stroke through the already established Korean stroke registry, and collecting both clinical and genetic informations. Our goal is to include more than 10,000 patients over 5 years. Our vision is to predict medication response and outcome using this data. This project is a 5-year initiative supported by the Korean government. For more details, please refer to my presentation scheduled for the next Tuesday morning. A 15-year experience of stroke registry taught me that if you want to improve the quality of stroke care and outcomes in our patients, we must begin by collecting their data. Identifying disparities gives us an opportunity to improve outcomes. By linking our registry data to other database or collaborating with other researchers, we can achieve more. My dream is I want to establish the International Stroke Registries Consortium. We can, through that, we can find differences among countries and regions. And if you can work together to address these disparities through collaboration. None of this would be possible without colleagues, patients, and their families. And lastly, I'd like to express how fortunate I am. I have two mentors, Professor Byung-Yoon, the leader of CRCS from Seoul National University, and Dr. Philip Gorelick from Northwestern University in Chicago. Merci pour votre attention. Thank you for your attention.